Hi, welcome everyone. Welcome to the Oregon Rural Health Conference presented by the Oregon Office of Rural Health. I'm Rebecca Dobert, Field Services Program Manager and moderator of today's session. We're going to begin with some brief housekeeping. First, I'd like to thank the partners whose support has made it possible for the Office of Rural Health to present the conference at no cost to participants. Many thanks to our gold partners, All Care Health, and the Oregon Rural Health Association, our silver partners, Eastern Oregon Coordinated Care Organization and the Oregon Association of Hospitals and Health Systems, and the River House on the Deschutes. Our bronze partner, RQI partners, and our copper partners, Westcom, the American College of Education, and Inquisic. Participants should have received an email with a link to our conference app, and you can use the app to visit our partners' virtual booths. And while you're there, you can enter to win prizes, network, and share photos of your hometown or region. And please don't forget to do a survey about the session. Survey completion is required for those seeking continuing education credit, and any completion gives you a chance to win a $100 gift card. And with that, let's begin. Your presenters for this session on equity and inclusion in rural healthcare are Amy Heikkinen, HIT Consultant, Quality Improvement Advisor at Stratis Health, and Candy Kanga Picar, Chief Nursing Officer at St. Charles Madras. And with that, I'm going to hand it over to Amy. The floor is yours.
Thanks, Rebecca, and welcome everyone to the Rural Health Virtual Conference. Today I'm going to talk about health equity and building that lens through the FLEX programming. And next slide. So some of our objectives today is just to discuss how we can look at ways to advance health equity through the FLEX program initiatives in the state of Oregon. And then we also want to start to discover some strategies and activities from other FLEX programs that promote those health equity initiatives. Next. And I just wanted to set some context. So, health equity, we've heard a lot, but why is it even more important now or at the forefront anytime you turn on the news, talk shows, etc.? Of course, we know about COVID-19, and we're starting to see some of those disparities show up in the outcomes. We're starting to see that people of color have a higher rate of infection, and we know that the virus isn't going after people just because of the color of their skin. We know that there's other reasons that these disparities are showing up. We have to point out that there's that civil unrest, so there's also that heightened focus on those inequities. And this has been playing out in other institutions as well, not just in the healthcare system. We're seeing data that shows it throughout the education system and legal system as well. And then, we have some hot topics. It's social determinants of health and population health. How are they woven together? How can we look at the communities that we serve in a different or more comprehensive way or in a new way that we've never really had to look at it before? Next. And so what is that context in the FLEX? What I'm really hoping that you can, as I go into this talk about a little part of health equity, I'm hoping that you can take that lens in your own work, in your own areas of the state, and think about that in those quality improvement initiatives. Think about how you can impact or take note in your financial and operational improvements. How can you put a lens to that population health improvement, rural EMS improvement? We're seeing some great work in there. Some of that innovative model development, and then that whole designation for critical access hospitals. Next. So here I have a graphic that's, and you may have seen this from CDC, and it's talking about paving the road to health equity. Health equity is when everyone has the opportunity to be as healthy as possible. But those roads all build an infrastructure so that it can support that. And we have to look at the policies, which are those laws, regulations, and rules that help improve population health. But we also have to keep in mind that that's federal, state, local, and organizational wide when we're talking about policy. And then to the left, we have those programs. What are those successful things that have been working? What are those interventions? That's your population health, your social determinants of health, motivational interviewing skills and deployment, and some cultural competency types of interventions. And then in the center, we have the measurement. So how can we support the advancement of health equity using evidence-based data practices? We have access with electronic health records to a lot of data. How do we look at that to support our efforts? We have the REL data, the race and ethnicity and language. We have other demographic data. We know some outcomes. We may have community or individual needs assessments based on our projects that we're going that are going on in the state. And then we may also have panel management, which, yes, it has a condition focus, but it also allows us the opportunity to cross-reference data, to get to know our community better. And part of this, what I want to point out with the measurement is, and health equity is you may have some pretty decent results in your health outcomes, but when you look down and drill down to segmenting to different populations, is it really equitable? When you put it all together, you may get a really good outcome, but when you look at certain communities or traits, it may look a little different. I know it does educationally in my hometown and in our healthcare system in Minnesota. Next, please. So to look at backing this up and talking about health equity, we really need to take a step and look at unconscious bias. So next we're going to look at a short video that sets the stage of what unconscious bias is.
The unconscious mind is amazing. It can process vastly more information than our conscious mind by using shortcuts based on our background, cultural environment, and personal experiences to make almost instantaneous decisions about everything around us. The snag is, it's wrong quite a lot of the time, especially on matters that need rational thinking. Here's a classic example. A bat and a ball cost £1 10p. If the bat costs £1 more than the ball, how much does the ball cost? Most people, including over 50% of students at some of the world's leading universities, get the answer wrong and say 10p. The answer is actually 5p. Many of us choose 10p without thinking. This is because our unconscious mind uses instinct, not analysis. So our unconscious is fallible. It's also biased. It makes snap judgments of people we meet, categorizing them according to gender, social, and other characteristics. In milliseconds, we judge whether somebody is like us and belongs to our in-group. These are the people we favor. So men might favor men, while women might favor women. However, we can belong to different in-groups, and we like to be part of an in-group that's powerful, which could mean a woman favoring a man over a woman. That's unconscious bias. All of us have it, and it colors our decisions without our realizing. For example, research reveals that if I were a man, you would be more likely to be nodding in agreement right now, because people pay more attention to a male voice.
So what is bias? And next. Bias really is that systematic error in judgment and decision making that's all human beings have, and it might be because of the way we think. It could be motivational factors, and it can be adaptations that we make to our natural environments. Next. So we have implicit bias, and when that's not checked or noticed, that can lead to, next, explicit bias. So even more demonstrative bias in our decision-making and actions, which we can see can lead to, next, discrimination that we can, pretty much, we know how to seek that out. We know when that's happening, and can even lead to the next one, which is hate. And that's all starts with bias, especially implicit bias. Next slide. So explicit bias, which can be called prejudice, are those attitudes and beliefs we had about a person or a group on a conscious level. So it means, I know I prefer this because, okay? And next is our implicit bias, which is, next, that refers to those attitudes, some stereotypes that are rooted in our understanding, our actions, in our decisions, but in an unconscious manner. So I'm reacting and doing it, but I'm not thinking about the reason I have that bias. And everyone has them because we're human, okay? So it's not whether you're a good person or a bad person. Bias, implicit bias, just happens because we're human with human brains. Next slide. So here are a few examples that you can tell the difference between explicit and implicit bias. Next. Okay, so refusing to see or treat a transgender patient. That's a bias that is very explicit. Next. Not hiring someone because you know that they are Muslim. Next. Using that derogatory language when addressing someone who's differently abled. Those are very explicit biases that are really easy to notice. On the other hand, implicit bias examples. Next. Preferring to treat an obese patient's chest pain with the suggestion to lose weight versus other treatments right away. Assuming that older employees can't handle new technology. Okay. And I may be guilty of that with my mother, so. And then favoring therapy for a biologically male child who wears skirts. Okay, so those are implicit biases. Those are ways that we make judgments or decisions, but we don't really realize the why. Okay, next. So that's why we're backing up all the way to implicit bias and how that affects health equity. I wanted to point out a tool, and you can see you have the web address here. It is on our Culture Care Connection website. It is 10 questions, does not take long. It is open to anyone. You do not have to log in and leave any information. And it's 10 questions that give an example with 4 or 5 different multiple choice that you can choose what answer you believe is right, all around implicit bias. And after you submit that quiz, it will go through and it'll tell you if you gave the correct answer or an incorrect answer, and then it actually gives you the research and resources to back up that correct answer. I find it really helpful to do in small groups just because it helps. Just the act of doing this quiz makes you kind of stop and think, oh, I guess I really didn't think about it in this way. I guess I really wasn't aware of that. So I just wanted to point out that this is one tool that you can use. Another thing that we do at Stratis Health is we can set up a certain link if you want a whole group to take it together and then see how the group aggregates. So we can answer more questions about that later. Next slide. So when we're talking about equity and bias, and especially in rural areas, you know, we tend to go to race, religion, political, ethnicity, and I really want to focus on bias can be about anything, and it's everywhere. So I'm going to give you a story about my personal relationship to bias, and I want you to start to think about, because everyone has one, about where you may have been an observer or a participant or a recipient of that implicit bias. So my story goes like this. It was a couple years ago, and I grew up in rural Wisconsin, and had always lived like in a, second, third tier suburbs. So not a city gal. You go there for concerts and sports games. But I had to go into a very large system in a metropolitan area to get a test. Esophageal cancer happens to run in my family. So I needed to get an endoscope done from some specialists at this big system. And just because it's a preventive thing, I understood why I needed to have it done based on my family history, which is all great. So I go to the big city, I have to park, I have to make sure I get to the right place. And I'm sure many of you have been to these big places where you walk in and there's one desk. And then at that desk, they direct you to go to, to the different kind of sub areas where that's where they're really going to call your name and bring you in. So I go up to the big desk and not really knowing that, I just say, hi, my name is Amy Heikkinen. I'm checking in for an appointment that I have at 10:30. And this woman looks up at me and says, okay, you need to go to the right and check in there. I'm like, cool. So I go to this other desk. I said, hi, my name is Amy Heikkinen. I have a 10:30 appointment. And she does her computer and she goes, well, I'm sorry, I don't have you listed. Of course, now I'm like, oh my gosh, what? Did I get the day wrong? How did I screw up? No, I don't have you listed. She calls someone else over. I'm like, no, I have a 10:30 appointment. I have a 10:30 appointment. The long wait that we kind of finally figured out what was wrong, I did have a 10:30 appointment, but I had a 10:30 appointment for a desk to the right. The desk that the woman at the front office sent me to was only for people who were going to get gastric bypass surgery. And because I'm heavier and overweight, she looked at me and said, you need to go to that to check in for your appointment. When really I needed to go to the endoscopy for that routine test. So I did get to my appointment. I was flustered. I was embarrassed and got it all taken care of. But that is how bias, that's one example of how bias played out for my story. Okay? So what I want you to think about is, do you have an impactful experience that you've had with implicit bias, a recipient of an observer, a sender? When people can relate to a story, that heart, that personal relationship, that personal connection makes, wanting to do something even more valuable. So when you connect that heart with the head and what we know that more action can be taken, especially when we address implicit bias as it relates to health equity. Next. So what contributes to our biases? And if you can, next, we have ego, next, experience, and environment, next. So what are these? Okay, our experience is those encounters, events, and occurrences that you had in your life. They could be your education, it could be life events. Do you have traumatic experiences? Have they been positive or negative? Who have you met? Things that you've seen. Okay, this could be if you've traveled abroad. This could be if you've tried any daredevil activities. Were you in band? Do you know lots of people? Do you have a smaller group of people? Those are your experiences. And then your ego, that is your true self, especially when it's contrasted with another self or the world. This is how your mind works. It's your identity. That could be your sexual orientation, ethnicity, gender, your IQ. It's your personal preferences and your tendencies. It's the chemical makeup of your brain. Are you an introvert? Are you an extrovert? How do you choose to respond to situations? Are you a glass half full person or a glass half empty person? And we might tend to think of ego in a negative way, like, oh, he has a big ego. But in this sense, it truly means just your sense of self, who you are as a person, okay? And then the last one is the environment. Those are the surroundings and conditions in which that you live and or work. That's your family, your city, your socioeconomic status. If there's power, privilege, what does your neighborhood look like? Okay, what do your communities look like? So one of the things that I will ask is for folks to start thinking about, well, what are my experiences, my environment, and the things about my ego that can contribute to certain biases that I have. Next. So I just want to go through, I'm not going to read all of these, but I want to go through, what are some of these case study examples? First, that an analysis of more than 1 million visits for children with symptoms of respiratory infections found that children who were Black were significantly less likely than children that were white to receive those antibiotics. That's backed by data. The second one, physicians are less likely to recommend physical activity for arthritis patients who are older than 65 years old than those in other age groups. Okay, that's where we see the inequities because of bias. Next. I'm just going to look at the second one. Primary care providers were more likely to rate visits with obese patients as a waste of time, and they'll spend actually 28% less time with obese patients than those of normal weight. Okay, it's backed by data. Another example. Next. The second one, medical students treating patients with shortness of breath were more likely to recommend lifestyle changes, and a big difference, 54 to 13% based on obesity, and more likely to prescribe medication to manage the symptoms if they were of normal weight. And the next. The second bullet point, physicians with a pro-white bias are 23% more likely to dominate conversations and 33% less engaged in patient-centered communication with Black patients. Okay, these are all examples of this is not okay. This is how it's showing up in our healthcare communities. Next. So why did I tell you my story? Why did I show you some of that data? What's so important is that one instance can have a ripple effect, okay? That one experience with the woman at the front desk could have a ripple effect for me, the recipient, okay? So press next, okay? So imagine I might feel negatively about that clinic, correct? Next. I could spread that negative feeling about that whole system, okay? Even the rural clinic that part of that system that referred that to me. Next. I might decide, you know what? That was too embarrassing. I'm not going to care about getting that test anymore because I'm not going back there. I'll be fine. I don't need the test anymore. And next. As a result, my health might begin to suffer. I don't get those routine tests. So then what really runs rampant in my family, that esophageal cancer, cannot be detected early. So my health could be affected, okay? And the impact to this about that bias could technically be a life or death outcome, okay? I'm exaggerating mine, but really, it can really affect people. And then what other ripple effects could come from this just based on my experience? I could start looking at people who looked like that woman at the front desk as rude, right? I could start looking at the people who were watching that take place where we can't find you, we can't find you, we can't find you, as people who are not part of my group, even though the one thing we had in common was that we were at the same place at the same time and we were all overweight, okay? So that's an experience that's going to affect my own bias moving forward and could affect my own health. Next. So what do? Individual awareness, okay? We can choose to identify. Now that we know that unconscious or that implicit bias exists in everyone, it's on us to identify those biases, okay? What do we do next? We assess. This is about taking perspective, checking those assumptions at the door, okay? Slowing down and saying, why do I think this, okay? And then making that choice. Choose to reframe by building empathy and being curious about those other folks that you see in your communities, okay? We can do these things in the moment, and we can also do those things with long-term strategies. Next. So how do we relate that to your flex context, okay? We really want to show that health equity isn't a standalone project. We don't have a project lead and a charter. It really should underlie all the work that we do. It should underlie it because we're all human and we're all working with other humans who have different ego, environment, and experiences than us, okay? Motivational interviewing has been proven to really get to meaningful referrals. What really is motivating a patient to work on self-management or their health? What really is contributing to their overall health in your communities? We know that we have to look at data and then analyze what do we already know about our communities, look at it in a different way. Are we really meeting the needs? And we have to look at those social determinants of health in relation to all of our projects. We know that there are bias and there are health equities based on what part of town you live in, okay? What type of insurance someone may have. Do they shop at the local thrift store or not? Okay, we have biases as to do they need to go to the food shelf or not? Okay, there are biases around socioeconomical things, about age, about what people look like. I mean, it can be anything. So really analyzing that. And then next slide. And yet, I have a ton of resources here. I'm not going to go through all of those. If you're interested, these will be available to you. Just know that these are some of the resources, not exhaustive at all. There are tons of things to guide people through implicit bias and how it relates to that health equity and shows up into our projects, especially our quality improvement projects. Next. Some more resources. And next. More resources. I like resources. And next. I do want to point out the two on the bottom of this page. The middle one is the IHI's implicit bias in healthcare. It's a YouTube video. It's super, super cool. And then the implicit bias quiz that I talked about, there is a link there for you and your teams or to pass that on. Next. More resources and next. I think we went backwards. Great. So this is the end of my time. Thank you so much for having me part of this virtual conference, and we will address questions later. And now I'm going to hand it off to Candy, and we're going to hear from her. Thank you so much.
Maayong adlaw kaninyong tanan. Hello, everyone. My name is Candy Kanga Picar. I represent diversity in healthcare leadership. It is my honor to present to you our Transcultural Care Project. In 2014, St. Charles Healthcare System hired me as the Chief Nursing Officer over 2 critical access hospitals. Back then, I was the only Filipino healthcare leader. My family was the only Filipino family in town. The community we serve is comprised mainly of Native American Indians, white, and Latinx from 7 different countries. As the Chief Nursing Officer, it hurt me deeply hearing the negative experiences that our Native American Indian population had expressed as patients in our healthcare system. Moreover, the nurses informed me that they lacked the understanding of the Native American Indian culture, which made them very uncomfortable when providing care. Hence, I made it a personal and professional goal to advocate for our marginalized population. Next slide, please. I have 2 main objectives for today's presentation. First, I'd like to share our success story in implementing evidence-based guidelines which promoted cultural care to our ethnic minority groups and equity of care. Secondly, I would like to provide a template for other hospitals to adopt transcultural care in their respective facilities. Next slide. Here's a quick overview of my presentation. I will be providing a short introduction about our facility, followed by the gap in our practice, specific aims, regulatory requirements, evidence-based guidelines, and how we operationalize these guidelines and the results of our project, and finally, conclusion. Next slide. St. Charles Madras Hospital is a 25-bed critical access hospital serving over 23,000 people in Madras and the surrounding communities. Formerly known as Mountain View Hospital, St. Charles Madras became part of the healthcare system as part of an asset transfer agreement in 2013. The hospital provides surgical services, imaging, intensive care, family birthing center, emergency care, and outpatient laboratory. Next slide, please. St. Charles Health System vision is creating America's healthiest community together. The key word here is together. We cannot tackle the changes we need to make to improve the health of our communities without partnership with the people we serve. Next slide, please. This is just a quick overview of our 2018 statistics during the time we implemented our transcultural care project. As you can see, we're quite busy even though we are a small rural hospital. Next slide, please. As many of you may know, the PICAD question format is a consistent formula for developing answerable, researchable questions. P stands for population, I for intervention, C for comparison, O for outcome, and T for time. So our PICAD question for this project is, in Native American Indians who are admitted as inpatients at a critical access hospital, how does implementing evidence-based, culturally competent care compare with the current state of providing non-cultural care for all patients, affect patient engagement and experience, measured by the participation rate and HCAHPS satisfaction score within 120 days. Next slide, please. We identified a significant gap in our practice. Our critical access hospital failed to provide culturally appropriate care, as evidenced by the narrative comments from our nurses, the anecdotal stories from our Native American Indian patients, and our senior executive team's deep concern for lack of cultural competency among our caregivers. Next slide, please. Our project specifically determined if implementing evidence-based culturally competent care guidelines would impact patient experience or engagement. We also wanted to provide our caregivers with a basic understanding of the Native American Indian culture. Finally, we wanted our hospital to be in compliance with the regulatory requirements and national standards as it pertains to cultural care. Next slide, please. During the course of our research and investigation, we discovered that professional organizations, government, and private agencies had established position statements and standards in response to the diverse cultural practices and communication needs of patients. In particular, I would like to call your attention to familiarize yourselves with the national standards for culturally and linguistically appropriate services, or CLASS, as established by the Office of the Minority Health, U.S. Department of Health and Human Services. You may access this information online. Next slide, please. For the purpose of this project, the Native American Indians who are admitted as inpatients and discharged from a critical access hospital are the target population because they comprise 30.1% of all the inpatients of our hospital. Jefferson County is composed of 19.2% Native American Indians of an estimated population of over 23,000 people. Next slide, please. We identified two problems. One is the suboptimal participation in the current patient satisfaction survey administered by Press Ganey. In 2017, our overall response rate was very poor at 16%. National average is 22%. Approximately only 78 patients responded out of the 475 patients we had. And 79% were white and 21% is non-white. And out of those 16 non-white respondents, only 8 were Native American Indians. Next slide, please. Problem number 2 is that we had a low HCAHPS top box scores. Rate the hospital, we ranked at 14th percentile, and recommend the hospital, we ranked at the 13th percentile. Next slide, please. We needed a theoretical foundation for our transcultural care project, and we chose Lineger's culture care theory of diversity and universality. We also utilized the 10 established guidelines by Douglas et al. And categorized these 10 guidelines into 3 main actionable groups. Next slide, please. Number 1, we established a PFAC, or Patient Family Advisory Council, to promote patient advocacy and empowerment. The goals of the PFAC were, number 1, review, update policies and procedures in order to reflect cultural care during birth, illness, and death, to assist in cultural competency training and education, and review the patient information packet, signage, and arts in order to reflect cultural care. Next slide, please. Our PFAC is composed of tribal leaders residing in Warm Springs, hospital caregivers, and occasional participation of representatives from the Indian Health Services Clinic. Next slide, please. Now I'm going to share with you a story of how important it is to involve the PFAC in making operational decisions. 6 years ago, our leadership team had good intentions in reflecting the diverse culture in Madras. Hence, a local artist was commissioned to create this wonderful, huge metal artwork at our hospital's main entrance. Unfortunately, we did not have a PFAC at that time. When our current PFAC tribal leaders came across this artwork, they were offended and disrespected because the Native American Indians depicted in this artwork were from the Navajo tribe and not from the 3 local tribes, which are Wasco, Payet, and Warm Springs. Next slide, please. In order to correct our major oversight, we asked our PFAC to work with the local artist and create a more accurate representation of our local tribal communities. The artwork that you see here is the latest version, but not the final one. Next slide, please. The second category of operationalizing the cultural care guidelines is education and training. We held a conference on transcultural care at the local Performing Arts Center. The nursing caregivers completed a self-assessment using a standardized tool to measure their competency before and after the training. The recorded video of the conference on transcultural care was also downloaded in the healthcare system's website as an additional reference for all caregivers to view. Next slide, please. At this point, I would like to thank the Oregon Office of Rural Health for providing the SHIP grant to our hospital. We used the funds to pay for our world-renowned guest speaker, Dr. Campinia Bacote, author and founder of Transcultural Care Theory. We also purchased the IAPCCR tool for competency measurement and provided follow-up educational sessions. The conference on transcultural care was attended by 110 participants from the hospital and the local community. Next slide, please. The last item is establishing a culturally competent organization. A few examples of this guideline are, number 1, our hospital enhanced one of our nurse managers' role to include being a liaison to the tribal communities. Number 2, the senior nursing leaders throughout our healthcare system met and revised all nursing job descriptions to include cultural competency as an essential duty of a nurse. Number 3, we also started holding monthly conference call with the Indian Health Services Clinic and reviewed patient cases, that is, Native American Indian patients who were discharged from our hospital. Next slide, please. During the water challenges at the reservation, our local healthcare leaders responded and provided 3 truckloads of bottled water and 6 toddler hand washing stations. Additionally, we just started an internship program by inviting the young Native American Indians who are interested in the healthcare arena. Next slide, please. Art is a very important expression of culture. We renovated our healing garden to reflect the Native American Indian culture, which includes the legendary figure, She Who Watches, and the salmon fish, which is a symbol of life and abundance for the Native American Indians. Next slide, please. Since we only had 120 days to evaluate the success of our pilot project, we developed 6 outcome measures. They are as follows. Number 1, participation rate of our Native American Indian in the patient satisfaction survey. Number 2, our HCAHPS stop box scores. And number 3, the percentage of inpatient caregivers who completed the initial training and education on culturally competent care. Next slide, please. Number 4, we also measured the inpatient caregiver self-appraisal. Number 5, developmental policies and procedures. And number 6, arts and artifacts. Next slide, please. These are the results. Approximately 37.5% of the participants demonstrated an increase in their perceived cultural competency after the conference. Next slide, please. The paired t-test results indicated that the conference in transcultural care resulted in a statistically significant difference in the scores of the caregivers prior to and after the conference. Next slide, please. The overall rate of participation by patients from 2016 to 18 showed a low, steady increase. However, the rate of the Native American Indian participation demonstrated a higher, steady increase. Next slide, please. The critical access hospital's percentile ranking for both HCAHPS questions rate the hospital and recommend the hospital demonstrated a steady increase each year from 2016, 17 through 18. However, the HCAHPS top box scores for question rate the hospital dropped by 2.8 points. Alternately, the HCAHPS top box scores for question recommend the hospital showed a steady increase each year. Further research is needed to determine if the critical access hospitals comparison groups have ethnic minority patients responding to each survey. Next slide, please. Upon the Patient Family Advisory Council's recommendation, St. Charles Madras Hospital changed our mode of survey of our hospital's Press Ganey patient satisfaction survey from mail-only mode to phone surveys. We had another discovery. The tribal leaders informed us that the Native American Indians have an oral tradition. They respond better to oral communication versus written. Consequently, the number of survey respondents and our top box scores have remarkably increased when we listened to our PFAC and demonstrated a change in our survey mode. Next slide, please. During the cultural summit, our ED physicians identified a serendipitous finding regarding the Native American Indian children having a genetic disease known as CPT1 deficiency. Delay in the care of these children could lead to a serious harm. After the summit, we worked with our system IT and implemented a CPT1 alert and treatment protocol in partnership with OHSU physicians to quickly identify and treat these children. Last year, EPIC recognized us for using technology in saving the lives of these children. During the course of this research project, we also discovered and started participating in the Central Oregon Health Equity and Diversity Council. Lastly, the Northwest Organization of Healthcare Executives honored me with a Transformational Pioneer Nurse Leadership Award in recognition of our transcultural care project in Madras. Next slide, please. The limitations of our transcultural care project were: 1, we have unpredictable number of Native American Indian patients. And 2, we have limited number of original research studies that demonstrate a relationship between culturally competent care and patient satisfaction. Next slide, please. In 2019, we launched our Latinx PFAC. Approximately 30% of our population have Hispanic backgrounds representing 7 countries. We had a great time involving them during our Family Birthing Center visioning sessions. The photo to your right shows the fabric representing the Latinx and the Native American Indian culture. We will use this fabric of life for our future hospital renovation. Next slide, please. We recently commissioned a local artist to create a metal artwork that would depict the 7 Hispanic countries representing our local diverse communities. This time, we are being smart in involving the voice of our Latinx PFAC. We definitely learned from our previous mistakes. Next slide, please. In conclusion, our transcultural care project was useful in transforming care experience and increasing the nursing caregivers' awareness of cultural care. Our journey continues with a promotion of equity of care, compliance with regulatory board and accrediting agencies, sustainment through policies and procedures. Our next step is to identify other groups who need a voice at the table. Next slide, please. These are just a few examples of the references we used for our transcultural care project. Thank you so much for allowing me to share our story. Back to you, Rebecca.
Thank you, Amy and Candy, for these presentations on such important work. We'll go now to the question and answer session. Hi, everyone. This is Rebecca. Welcome to the live Q&A. And I just want to extend our apologies for the technological difficulties and want to say we appreciate the grace of our presenters and attendees while we repent, reflect, and reboot. That being said, we did have a question come in the Q&A, and I want to make sure that we get to it. Thank you guys so much for these great presentations on this really important work. And our first question is from Angela Leach for Amy. She wanted to know, how do you recommend we address fat shaming and ableism among providers?
Very good question. Have them take that quiz, first of all. You know, it's each one of those issues is something to tackle in a system, whether it's fat shaming, whether it is about socioeconomic. It doesn't matter what it's about. It's really the education about how those thoughts can change the way that care is given. Share my story. Talk about it. Talk about the resources that I have on there, where there's actual valid research that says care is given differently to certain populations. And then take it a step further and say, you know, let's talk about this in an open way, but then let's also look at some of our data. Do you have electronic health records? Can you look at your data to show, okay, those with the BMI over or under, are they getting different care even though they have the same diagnoses? So really doing that deep dive of what is really happening and having those hard conversations.
Great, thank you so much. Great answer. Candy, I have a question for you. How do you start a patient family advisory council?
Thank you so much. That's exciting to answer because it was tough for us. But the first step is we did an inventory of our community in terms of demographics, gender, ethnicity, sexual orientation. And we asked around, who should be represented at the table? They are our community members. So we asked around for community leaders, business owners, etc. And believe it or not, they were so excited to participate. So we gathered together, we set up a date and time, and we made it fun. The first 30 minutes is really important to have socialization. It's all about relationship building. So we did that. And then after that, we started with our business operations, which is have them first develop and sign a charter. And after we created a charter, they made a commitment to meet every 2 weeks. And I was really surprised. These community leaders came together and really helped us develop policies and procedures in the hospital in order to improve the care of our patients. Thank you.
Thank you. All right, and I have another question, which I'll address to Candy, but I'm guessing Amy may have some items to weigh in with too. What are the 3 major steps to work towards cultural competency?
So the 3 things that everybody should consider is the first one is really creating and developing a patient family advisory council. Ask yourself who needs to be at the table. The second step is that cultural training and competency. As indicated in our research project, we did see a significant improvement in our caregivers' cultural competency prior and after the training. And then the third piece, you've got to have all the leaders from the senior leadership down to the front line to understand and support that we need to be engaged in cultural care. And what that means is changing your policies and procedures. Again, creating specific cultural considerations to better take care of our patients, and then involving human resources to hold people accountable. If they're not on board, they have to be on board. Every employee needs to be engaged and making that an essential duty and function as part of their job description. So it's a carrot and a stick. Thank you.
I totally agree, Candy, especially about that leadership and support, about having all staff, everyone in your system be on board after having education. Really taking that time to have that personal reflection, and then that time for each person to figure out what's in it for me. We call it the WIFM. But why do I care? Why should I care? How does it affect me? And when they make that connection, then they get the why. So that's number one. So I agree with everything you said. I would also add, look at your data. Do you really know? Do you really know the communities that you serve? Again, not looking at everything, don't boil the ocean, but what is your data telling you? Where are there opportunities and gaps and successes that you can learn from? And that's exactly what Candy did with her council.
Thank you, Amy.
Mm-hmm. Great. Well, we are at time for the session. So I just, again, want to say thanks to Amy and Candy for your really terrific work and for sharing with us. I know we had a lot of activity about this session on the app. And so for anybody out there who still has questions or who has, if there are unanswered questions in the app, we'll review them, and please submit them to the Office of Rural Health, and we'll make sure that the questions and the answers are posted with the presentations and the slide decks and resources online. As a reminder, I did post a live link to that bias quiz that tool that Amy mentioned in her presentation and linked to. It's a really great resource. It's a good starting point for so many kinds of organizations. So we really appreciate that. So thank you so much. I hope that everyone will join us for tomorrow's opening session. We have a really great presentation on oral healthcare queued up for 9 a.m. tomorrow. That session is called Impact of All Care Health's First Tooth Training on Children's Receipt of Oral Health Assessments, Fluoride Varnishes, and Other Dental Services. And I want to also note that that presentation discussed the impact of the COVID-19 public health emergency on oral care as well. So it's a really great presentation. Thank you, everyone, for attending. Thank you so much for taking this journey with us through our virtual conference, day 4. We appreciate you and we thank you. Thank you so much. Thanks, Candy. Thanks, Amy.